Um, so we'll get started. So
Sure.
hey everyone, welcome to our third alumni speaker series event. My name is Walid Ahmad, and I'm the M1 class president. Just briefly, a big thank you to Dr. Diorio for helping lead this effort and bringing this to fruition, giving us a platform to do this, as well as a tremendous support from Dr. Buckley, Dr. Navarro, Dr. Walbin, and Kathy. So just a brief introduction of the Alumni Speaker Series. So for a lot of us, we had mentors and role models that sort of paved the way for us to pursue medicine. We wanted to sort of continue that now that we're M1s and M2s and highlight the importance of finding mentors as we chart our path forward. We aim for this to be a continual program every few weeks with different speakers, as well as an opportunity to network here and learn from those that walk this path before us, and hopefully get a glimpse of the passions they have within medicine and outside of medicine. So with that being said, it's an incredible honor to introduce Dr. Eduardo Rodriguez. He's the Helen L. Kimmel Professor of Reconstructive Plastic Surgery, as well as a chair of the Hans-Jörg Wyss Department of Plastic Surgery at NYU Langone Health. Dr. Rodriguez, thank you so much for joining us. It's an incredible honor to have you here, and thank you for taking the time to speak with us.
You're welcome. Glad to be with you.
So you have a very unique story and journey from where you began as a dental student to medicine. What was that journey like, and how did you end up in medicine?
Yes, I'm always very honest of how I got here. Initially, I applied to medical school, and I just really didn't have the grades to get in. Dental school had always been on my mind, so once medicine didn't happen, dental school was kind of the simple solution. And actually, when I went to dental school, I didn't really think about medicine again. Went to dental school, and then I actually thought I wanted to be an orthodontist. And I got interested in oral surgery, oral maxillofacial surgery, which was kind of a hospital type residency, which I thought was interesting. I did a sub-internship at University of Miami, Jackson Memorial Hospital. And then I also did sub-I at Mount Sinai in New York, because my residency was at Montefiore Medical Center at Albert Einstein. So I thought, wow, this could be a cool career. And at that point, oral surgery programs were introducing the concept of getting a medical degree while you were in residency. But even that, I had no interest of going back to medical school. It's one of those things in life, and when I'm very honest, you know, when you haven't done well in something or you failed at something, the last thing you want to do is remind yourself of trying to do that again. So I kind of moved on beyond it, and I went to an oral surgery program in New York and spent time there for 4 years. And then at that point, I had a good mentor that told me, you're probably going to want to go to medical school and do this combined kind of residency. And I just didn't want to accept it. But sure enough, I decided to apply to medical schools that had a relationship with an oral surgery program. And I don't know if MCV still has a relationship with the oral surgery residency where they have the combined training where they do 4 years of oral surgery and 2 years of med school. So I don't know if that still exists there. But programs still have that. And it ended up being that I applied to programs throughout the nation that had an oral surgery residency. And the only one that responded back to me was actually MCV. They had an opening. One of the oral surgery residents had dropped out, and a number of us applied for the position. And I'm so blessed that MCV interviewed me, and I got accepted to medical school. And as difficult as it was to go back, because I was older than most of the individuals there, because I had already done 5 years of residency before I got there, it was the most liberating time of my life, and the education that I received at MCV was phenomenal. So I went to medical school there. It was kind of, I jumped into the second year class, which is great. You kind of do all the pathophysiology, everything, and it was kind of in mechanisms of disease, which is an interesting model to learn. We were the first class to have that. Great year, learned a tremendous amount of medicine. I did my, that summer I took step 1, and in order to graduate on time, because I wasn't going to graduate with my class, I was only going to do the 3rd year rotations and then start residency July 1. So I took step 1, and while I was taking step 1, I was already started OBGYN, and they put me on Gyn-Onc, which is still one of the toughest rotations, at least then. So they kind of, I was volunteered for that tough rotation there, but finished at MCV, got my medical degree, and then at that point I went on and did general surgery and plastic surgery at Johns Hopkins, and then I decided to do time in Taiwan to learn reconstructive microsurgery, and then I started my practice in Baltimore, and then eventually led to this place. So it's kind of a shortened version of how things went about.
That's an incredible story. And I had it all written out to kind of introduce you with everything, but I wanted to kind of get your story, like the personalized journey of like how it started with dental and everything. So Dr. Rodriguez also leads NYU's vascular composite allotransplantation program, which encompasses face and limb transplantation. You and your team performed NYU's first transplant in August 2015, and last year, in August 2020, did your fourth face transplant as well as your first bilateral hand transplant. So for us, we're starting really early in our careers. We're kind of our M1s, M2s, M3s. And you kind of already hinted at, you saw failure and hurdles early on in your career that kind of shifted you away. And now kind of you look towards where you are. Did you enter dental school and medical school with like that level of confidence in yourself, your leadership, to be able to achieve these things? Or were there certain moments and milestones along the way, certain mentors that sort of kind of elevated you and pushed you forward?
No, not at all. Yeah, I'll tell you, I've had a lot of great mentors. And that path that I described exactly as you pointed out was not scripted. Just one thing led to the other. And even sometimes, as we've read and know, and there's a lot of literature out there, sometimes we fail our way to success. But I think it's the inability to give up. And I will tell all the medical students and all of you that are aspiring professionals, you receive sort of a calling, but I would say don't give up so easily, because a lot of us, it's not so much about winning the race. It's about falling off the horse and getting back on and riding. And that's going to happen a lot in life. It's kind of a normal situation. I think what all of us need to have, and I've been fortunate that I've had great mentors along the way, is that you have to have a certain amount of grit. It takes a good amount of tenacity to not give up. All of us, and I've had the great pleasure of being around remarkably successful people throughout the nation in all facets of employment. And I would tell you that all of them, most of them, even incredible athletes, names that many of you know right away if you were to hear their names, they will all share very common stories of failures and adversities that they'd had to overcome in order to achieve success. So from my standpoint, when I went to dental school, although I had not gotten into medical school, that was my next path. I was going to pursue this path and be as best as I possibly could. And I never really felt like I failed, but the reality is that I was not accepted. And I think it's important to come, face the fact of things that happen to you in life. And maybe I didn't study as hard. Maybe I wasn't the top student. And you have to accept those things. And then if there are things that you need to improve, focus on how to make them better. But you have to be honest to yourself. I will tell you that when I was in my oral surgery residency training, I just wanted to get the best training possible. But I was fortunate enough to meet people along the way that kind of guided me and said, you're going to probably need to go a little further because this may not be enough. And initially, it's hard to accept these things. But people that have your best interest in mind, and when you meet mentors are the people that are going to tell you the things that maybe you don't want to hear. And we call that truth. And it's those people that actually sit down and provide constructive criticism and guide you. They're the ones that you should cherish the most, because those people really care for you. The ones that just pass by your life and pat you on the back and tell you everything is great, it's not that they have anything negative to tell you, but that's very superficial at times. It's the people that actually sit down with you and provide constructive criticism and help you, that want to see you do better. Listen to those individuals, because there are going to be few of those throughout your path. But I was very fortunate to have several of those individuals in my life along the way, whether it was in oral surgery training. I was very fortunate with some great mentors at MCV, and then when I went on to Johns Hopkins, and still today, in my position, as a chair of a department of which I never knew that I would do. And I have to also go back that I didn't even think I was going to be doing face transplants. This was nowhere near in my horizon. But I think your mind needs to be open. All of us want to try to solve problems. I got involved in the field of reconstructive surgery. And when I came back from my microsurgery fellowship, I was seeing patients, there were soldiers that were coming back from Iraq and Afghanistan that I was asked to assist that had horrific injuries. And it was there and then that we kind of realized that standard conventional surgery for reconstruction was not going to solve their problem. So these problems lead to solutions. All of us are uniquely talented and smart enough to help out people. That's why we're in medicine. That's why we take a Hippocratic oath, because our goal is to care for those when they're in need. It's not just the patients, but it's the families, it's the entire support structure that we care for. And it's our responsibility to burden that on our shoulders. And all of you now in medicine have witnessed probably one of the greatest health crises that I've personally witnessed in my life. And once again, as healthcare providers, we went to the front lines to help out as many people as possible.
And that's incredibly reassuring and wonderful to hear. And it's a common theme. So we've had previous speakers that kind of talked about, I didn't understand like my career's passion or purpose or like the foundational things I was going to do. I'd find so later on in life. I think, especially for us early on, we're kind of, I know for me, you feel sometimes I have to figure it out now. You're in a shortened time frame. It's really reassuring to see like your career is a long journey. You might find it later on down the road. So how did you find plastic surgery and end up doing what you're doing now with face transplantations?
Right. And just to echo that same sentiment, I think it's very important to understand, Waleed, that the fact is we're so used to it. All of you, you went to high school, you went to college, you went to medicine, you're in medical school, now you got to choose a residency. Like life is that way. There's no question that there are steps that we all need to take. But don't be so surprised if things kind of shift along in a certain direction that you may not expect. The other thing that I would say that there are wonderful things that happen in the course of life. And not to sound cliche-ish, but sometimes we're pushed in a certain direction that we may not want to accept, that actually ends up being the best thing that ever happened to us. So it's the ability to kind of listen to our surroundings, and whatever situation presents itself, embrace it. Whether good or bad, embrace it and let it be a lesson for you, and that will propel you in the positive direction. So once I did completed my oral surgery training and did medical school, at that point, I was already a practicing oral surgeon, so I had a medical degree. The reality is I probably could have stopped there. The minimum that I needed was a year of some form of residency, and then I could practice as a physician. But I kind of realized that it would be best to supplement my training with something. And initially, being an oral surgeon that we worked with the teeth and the jaws and those kinds of structures, I thought that I would be interested in what we call congenital craniofacial surgery, which involves the care of patients commonly that are born with a cleft lip and a palate, skull deformities. And I thought that that would be kind of the typical approach that I would take. I knew that that would require training in plastic surgery. So I kind of thought plastic surgery was probably a specialty that was better suited for me. I like the idea of a specialty that I could care for children and adults and elderly. I could work from head to toe. So it offered a kind of a wide specialty, and I could also focus on the facial region. So I chose plastic surgery. And in plastic surgery, I had a great mentor, the chief of the division of plastic surgery at Johns Hopkins, Paul Manson, who was a wise man, still is, and provided some guidance. And I would tell him, well, I think I want to do this, and I would do that. And he never told me no, but he would kind of help me home in and kind of narrow what he thought would be a good fit for me. And that was kind of the direction I took. So I pursued within plastic surgery the field of reconstructive microsurgery. And I thought that would be great for my practice. And I like patients that had certain deformities. For example, when you cut a portion of the jaw for a benign or malignant tumor, an antiquated form of reconstruction is you would take some bone graft, you would create some form of a mandible, but the more sophisticated way of reconstructing a jaw was to take a bone from the leg with blood vessels, we cut it and shape it, and then we insert it into the bony defect and we connect it to blood vessels. Now, this was a technique that had become in vogue when I was in training, but I had limited experience. So that took me to Taiwan. And the reason I went to Taiwan, and I wanted to go somewhere where they were specialized in this field, this new burgeoning field, and I wanted to work with experts that did a lot of it. So I went to Taiwan. I came back to Maryland, where I had a joint appointment at Shock Trauma University of Maryland and Johns Hopkins. And at that time, we were in the midst of a war with Iraq and Afghanistan. And as I said earlier, I started seeing these patients with these horrific deformities. And there was a person by the name of Maria Siminoff at the Cleveland Clinic that was doing research in face transplantation. And she actually came to visit us at Johns Hopkins and give a lecture to the residents and the faculty. And my mentor there, Paul Manson, told me, this is what you should be doing. And it seemed like it was the appropriate fit. But keep in mind, we had not done a clinical transplant. The first clinical transplant occurred in 2005 on Isabelle Denoir by Michel Dubernard and Bernard Dubuchel in France. And that was life-altering for me. We got involved in working with the Department of Defense and the Office of Naval Research as part of the Wartime Protection Program to develop a strategy to care for the wounded soldier returning from Iraq and Afghanistan. And that was titled the Face Transplant Program. And that's kind of how that began. In my experience in dealing with facial injury at Shock Trauma, I dealt with all types of injuries, high-speed motor vehicle collisions, ballistic injuries, gunshot wounds. And there's just some patients that despite everything that we have in plastic surgery, the quality of the result is really unacceptable. They have diminished feeling, diminished animation, inability to eat, speak normal. So all these deficiencies were things that I saw. And I began doing research on performing face transplants. And we began at the basic science lab. We moved into an animal model. And after numerous years, we decided that it was time to move forward with the clinical face transplant. And I performed my first one in 2012 on Richard Lee Norris in Maryland.
And that's incredible, just to see kind of how methodically your journey kind of things sort of spontaneously fit together, and it kind of like built you up to where you are today. You gave an incredible TED Talk in 2013, and I'll post a link into the chat now for anyone who wants to watch it after. And you kind of led with it saying, repetition is a mother of mastery, and how over the course of your career, you've been challenged when people didn't believe in you, and you kind of had a pursuit of excellence, whatever you wanted to do. I wanted to get back to, for us starting off, I hear a lot of my colleagues say, there's a sense of imposter syndrome or insecurities as, as we progress in our career and kind of, build the skills and knowledge and confidence we hope to have as attendings. What were the did you have any insecurities or imposter syndrome when you started out your career?
Absolutely.
Yeah, definitely expand on that. We'd love to hear.
So a couple things. You have to keep in mind that I was a dentist that went into medicine, that went into plastic surgery. Now, I was quite liberated once I got my medical degree. But there are some individuals, like myself, that were dentists, oral surgeons, got their medical degree, but they still went back and kind of stayed limited in that area. And it wasn't that I did not want to be that person, but I felt, God, I have such an armamentarium of abilities. And there's so many unsolved problems that I want to take advantage of this. So the one thing that I really forced myself to do, rather than gravitate to the area that would be the easiest, in other words, let me just work in the mouth again or around the jaws, I forced myself to take on those challenges and work on those things that I knew that I felt insecure about. So sometimes forcing ourselves to do things In surgery, commonly, and it's no different than anything else, we like to do those things that come easy. If we're good at math, but we're not good at English literature, we always go to math. But I think it's the ability to force ourselves to train to take on the difficult challenges. Whatever may be hard for you, don't shy away from it. Don't give up on it. Just keep at it, because we're all intelligent, all of you, at an upper echelon level of education. There is nothing that you cannot accomplish. There's no doubt in my mind. Even still today, I have insecurities. When I take on difficult cases like this, for example, on Joe DeMeo, when I performed a face and double hand transplant, if you think about it from a practical standpoint, yes, I've done face transplants. I've never done a hand transplant, and reputable surgeons have attempted this type of operation with a face and two hands twice before, and they were not successful. So that in and of itself can lead to certain insecurities. Why would I accomplish it? Can I do it? Am I being egotistical about it? You know, you really got to break it all down. And when I fundamentally think about those problems, I simplify it into face transplants have occurred successfully. I've personally been part of 3 successful face transplants. Hand transplants have successfully been performed. There is no fundamental reason that we cannot perform them both successfully. So rather than being egotistical, and I think it's also important, never be arrogant. There's never any need to be arrogant. Arrogance is only an expression of an individual's insecurity. Humility, which is something, a characteristic that we should all carry, is an endless reserve of strength. Because when you're humble, you're not afraid. All of us have insecurities. All of us have fears. We're not superheroes. We're just normal people caring for patients. But if we're going to take on a challenge, we have to study it well, and we have to think about it well. When we're performing a difficult task, like a face and a double hand, it's not something I'm just going to take lightly or just think about it and let's do it. Because there are individuals' lives that are on the line. And there's also individuals' reputation. There's the institutional reputation. There are many things that are on the line. And I also want the field to advance. So we're going to be very methodical. We're going to think about it. We're going to break it down into basic scientific principles that we're going to study it, and we're going to think about it no different than all of our forefathers in medicine that have made remarkable discoveries. But they've all been challenged by some difficult entity in medicine that has compromised humanity, and all they want to do is affect human affliction and make it better. And that's all we do. But we all have insecurities. We have difficult moments. Don't shy away from them. You're not alone, but you will overcome them. We have that in our internal fiber to overcome adversity. We're going to have to work. It's not going to come easy, but we can accomplish it.
And that's a very strong message and incredibly impactful, especially, you know, we're listening and kind of growing and developing our own professional identities. Sort of building on that, I wanted to ask you about leadership. You know, you are leading a 100-person team in a 24-hour surgery. You know, and like you said, you know, a lot of times the reputation of the institution, you know, you're taking on challenges where others have failed. How did you develop those leadership skills? And how do you deal with that responsibility? You know, where everything, it sort of feels like can fall on your shoulders, where you are the face of innovation of where you're operating, where very few people or no one has really gone where you've gone. And, you know, you're kind of there alone. So how do you deal with that responsibility?
Well, it goes back to what we mentioned. You know, I know how difficult the task is. I'm very honest with my patients, and I tell them I've never performed this. Patients have died. Qualified surgeons have failed. But I'm not going to perform this operation on you until we practice. So I put together a team, and in that team, I tell them all the same thing. First of all, we're physicians. Second of all, we're surgeons, which means all of us have an ego. It doesn't matter. But we're going to put our egos in our back pocket, and our primary objective is to perform this operation successfully and get this patient out of the operating room healthy and alive. How are we going to do that? We're going to begin working together. So we begin in a simulation laboratory. And I pick the members of the team. I specifically create the teams for the right hand of the donor room, the left hand of the donor room, the face of the donor's room. And I create the teams of the right hand of the recipient room, left hand of the recipient room, and the face team. And I want to see how those individuals work together. There can be no personality differences. And I have ultimate decision-making process on how I want the team to work. If they're not working well together, it's not going to work. And it's important. I wouldn't bring people together that are not going to work well together, but I do have to make some difficult decisions of individuals that I feel are harmful to the end result and the quality of that patient that I need to remove from the team. But these are conversations that I have in a dignified manner with these individuals. And I tell them, you're a talented person. I have a lot of respect for you. But this mission is far greater than you or I. It's about all of us working together. And I know that you're going to be upset, but I can't have you be upset because I have one primary objective. This operation has to be successful. And I do apologize for that. So I treat everybody with the greatest respect and dignity, but I do have to make hard decisions. And I'm there from the beginning to the end. People often ask me, how many breaks do you take? Do you sleep? I can't. I don't do that because this is my responsibility. This team is my responsibility. This patient's my responsibility. Not even getting them through the surgery. They're going to have difficult problems after surgery, but every issue that happens is going to ultimately fall on my shoulders. But I have a great team of individuals that do help me make the right decisions. But I let them know that it's ultimately my responsibility. And that takes the pressure off them. But I wouldn't take such a burden like that if I didn't know that we would not be successful. So it's something that's very calculated, it's planned. But yes, all the responsibility falls on my shoulder. But I treat every member of my team, not only the surgeons, but the scrub techs, my nurses, everyone that's involved, the critical care specialists, the individuals that work from the organ procurement organization. I treat them exactly the same way that I'm speaking to you right now. And I think it's that level of familiarity, but also respect that we have a difficult task at hand and I will be required to make difficult decisions. And none of that is personal. It's just about getting from point A to point B successfully.
And that's a great insight into kind of, leadership, decision-making, building teams. I know our deans in our school kind of really emphasizes early on that medicine is a team sport. And there's only so far you can go just as an individual player in this field. It's not very far you can go as an individual player in this field. Exactly. Sort of shifting gears a little bit, you're taking on such challenging projects, and I know you're incredibly busy. And one of the questions that came up, they wanted me to ask you was, how do you integrate your home life and work-life balances? And how's that changed, from your early academic career into now, in attending in chair as you're taking on more and more responsibility?
That's an excellent question. I would say that everything that you do in life, live it to the fullest, which means I love my family to the fullest. I love my wife to the fullest. And I think it's important to partition. When I was younger, at home, everything that I would talk about was medicine and this and that and the other. And what you realize is that you have to learn to divide that a little bit. You have to learn to break that up. And it goes back to the same thing. Treat everybody with dignity and respect. There are times that you have to separate your work life from your home life. I've gotten better at that as I got older, actually. But we're so passionate about our work. And you have to realize that we probably spend more wake hours in our work than we do in our home. So the time at home, whether it's in the evenings, with dinner, or on the weekends, they have to be fruitful. It's never enough, right? It's like vacations. Vacations are never long enough. when you're with your family and you got to leave, they never want you to leave. But it's how we say goodbye to each other. It's how we treat each other. It goes back to respect and dignity and kindness. And it really comes down to love. I love my practice. I love my residents. I love my department, my specialty. But I also love my wife and my family. And, you know, I live life to the fullest. I love passionately. And people know that. But you do have to be able to separate them. And I love to enjoy myself. I love my outside activities. I love playing golf. I love running, doing my exercise. So I do try to partition all of that. And it's very important. I think without my normal life, I can't have the work life that I am so passionate about, because it does take a tremendous amount of time, but you do have to balance it. And I think when that's not in balance, it affects you personally. And I've seen that it's affected me personally. And there are times that you got to make sure. That's why it's important to take some time off. We take vacations. You know, when I'm at work, I'm full speed. But if I have some time down in the weekends, even though things can happen to patients and you're always attentive, it's really important to shut it down, take your mind off, read a book, do some exercise, get outside. So you really have to balance that, and you have to work at it, because before you know it, life goes so quickly. And these things will get absorbed from you, which will lead to an unhealthy life. So I work constantly at balancing all those elements, but I live passionately, I work passionately, and I enjoy my life to the best of my ability. So I keep all that balance, and I've gotten better as I've gotten older. And that's going to come. It's not going to happen right away, but keep that in mind. Keep it all balanced and care for those. Remember, give love back for those that are with you every day, by your side, that have supported you. And it can never be selfish. It can't all be about you and supporting you, because the people that have helped you get there and will continue to be by your side to be successful, they also need to be cared for. You know, you have to water the plants, you have to give them sunshine. Everything around you that helps you become successful is going to need to be supported and loved and cared for in the same manner that you receive that level of support.
That's very, very powerful. So sort of building on that, what is as being chair and leader in your department, what is your typical week like, your day-to-day like, being an academic physician, being a surgeon, being someone who's, you know, bringing in research and grants and kind of doing innovative things? So what is your typical week like? And also broadly, you know, how do you plan like your year as far as professionally?
Right, so let's say this is my typical week. So in the morning, I saw patients till about 12:30, ran a little bit late. And then I start with my kind of first meeting with all of you. And then I'll have meetings all the way till about 7 p.m. So that day ends, go home, have dinner with my wife, relax, have a glass of wine, probably return some emails, and slowly shut it down, go to sleep relatively early. Tomorrow is a full operative day. So it's a big day. I'll operate all day. And in between cases, I'm returning emails, managing administrative things that we all do. Wednesday, it's our educational curriculum, where we have grand rounds with our residents beginning at 6:30. That goes to about 8. And then at 8, I have meetings till about 9:30, and then I start seeing patients from 9:30 all the way to about 5:30. And then I'll have meetings from about 6 to about 8 o'clock at night. Thursday, I go back to the operating room. And then Friday, I also operate. And that kind of ends the week. It's an unusual week because it's a busy operative load. But we've found that post-COVID, since we had that downtime, we're trying to catch up with a bunch of people that were kind of put aside their surgeries. And they were kind of, especially now, things are getting more normal. So everybody wants to get back on their typical routines. And then when the weekends come around, I really shut it down. I exercise. Golf season's coming up. I love golf. So if I get invited to play golf, I'll play golf, as I will this weekend. But Sunday, when I'm home, I'm already planning the week. I'm looking at my schedule. I meet with my residents, we're reviewing manuscripts. We're thinking about what's going to be, evaluating patients that are coming up for the next transplant. What's the next challenge that we're thinking about? We're looking at our research portfolio. I have meetings with my faculty, kind of guiding them, mentoring them. I have potential new recruits for my department. What are areas that are beneficial, which will help the health system grow? And these things all seem like, wow, there's so many things. But I will tell you that all of these things, all of you can do. No one taught me to do these things. A lot of this stuff is on-the-job training, and you kind of go along the way. And we gain more responsibilities because we have to be organized to do the things that we do. And I love caring for my patients. I have a busy clinical practice, which is very important to me. I love my research projects, and I love my researchers, and I love all my faculty. So all these things are things that I'm very passionate about, and I'm very much involved. But we lead by example, right? And that's important. I don't leave any task unfinished. I'm pretty decisive in how I want to do things. I have an idea of the direction where I'd like to take our department, and these are the things that I manage on a weekly basis.
And so my last question for you, before we kind of open it up to discussion for everyone at large, is there anything else you want to or feel you need to accomplish in your career to be satisfied? And how will you decide when it's time to retire from medicine and walk away?
Those are excellent questions. Currently, I love what I'm doing. I love everything that I'm doing. And when things are going well, I would say that we always want more. And for me, wanting more is continuing the success of my department. We have the #1 residency in the nation, which I want to maintain. It's easy to slip down on things. So I always have to think about what maintains our level of education up. How do we change the curriculum to make sure the residents of tomorrow continue to be leaders? How do I influence medical students? So I'm always thinking about things that will impact our medical students, our surgical residents, my faculty, my staff, how to keep all that going. So it's never enough. I just don't know. I will tell you, I never know what the next challenge is going to be, but I'm always enticed. Problems get presented to me, and before I say yes, I want to think about it. Well, but I'm in a fortunate situation that we can take on challenges like that, and I like them, but I still think I'm pretty young, I'm vigorous, I'm hungry, I want to keep solving problems, and I love mentoring many people. But I do realize that at some point in life, I won't be able to do this anymore. The people that taught me, and I would say a lot of my predecessors, that never really thought about retirement. And I often tell people, I think about retirement a little differently. I think retirement is not like this day comes and I'm going to stop everything and I'm going to start growing tomatoes or something. I'm going to grow a garden. I think retirement is a phased approach. All of us are in a position that if our minds are working and our body is working, we can stay involved in things for a long time. And I may not be in a position maybe to perform transplants or these long operations that are 12, 16 hours, but maybe my practice will evolve to a form where I could do smaller procedures. Maybe I'm involved more in education and training of medical students and residents. And I will do that as long as I can, as long as I'm physically and mentally fit to do it. I will do it as long as I can. I recognize that there will come a time where I can no longer lead this department or do these complicated operations. And then it's someone else's job to do far better than what I did and take it to the next level. And that's our responsibility. We step away, let someone do this smarter, better, faster, and they will. And then I kind of go into a different phase of my life. I don't know when that will be. I'll be 55 soon, so I still got some time in me, but I think about retirement as not, I'm stopping medicine, I'm leaving it all alone. I think medicine offers a great opportunity to all of us where we can be involved in the care of people for a long time. Whether we do surgery or not, I think our minds and the ability to read and stay on top of the latest cutting edge medicine allows us not only to care for patients, but influence individuals like yourself to mentor, because I think having people mentor us along the way is just an invaluable resource.
And with that being said, I want to open it up to everybody else, get in a couple questions here before you have to go. So
Sure.
you have any questions from anybody attending? Otherwise, I can ask another question.
Sure.
I can continue this all the time, yeah. Going back to your time at VCU, what was it about VCU that kind of left a professional impact on you, and that you remember most fondly about, or MCV?
Yeah. Yeah, so I have very fond memories. I lived in Tobacco Row apartments. I don't even know they exist. And I do remember parking sort of at the bottom by the bridge and taking my walk up to the primary auditorium where we took all our classes. Living in Richmond was it was a special place. You get a flavor of the South living in Richmond. But the thing that I love the most is that my class, a medical school class, everybody in there was so endearing and they were so welcoming. They were much younger than I was, but even though I felt a little bit older, they just made me part of their class. And I remember going to the little parties and I remember Shockoe Bottom and all these places. It was kind of refreshing. Going into and the professors were all great. I remember at the end of classes going and asking them questions. They were all so warm and welcoming. There was never a sense of, I'm the professor, you're a medical student, I don't have time for you. I never felt that at all. And it was actually great. We used to have lunch in between. I think they had these little food trucks. I don't even know if they have these things anymore. Little food trucks around the campus, and we could sit outside and talk to each other. And that was in my second year. And then in my third year, I thought the clinical rotations were excellent. Not having had experience at any other medical school, but I would say that the education there, the level of camaraderie with the medical students and the level of teaching from the faculty was truly phenomenal. And I owe MCV a great deal because they really taught me how to become a physician. And I went to one of the top training programs in this country at Johns Hopkins, and I felt that I had a truly sound medical education, and I was able to exhibit and explore it to maximum capacity there. So great times. Richmond was a great city. Those were also the first years that I lived with my wife. My wife and I got married in 1997, and I started medical school right after that. So it was a nice place to start my life with my wife and as I moved on. So only the positive memories, if I remember.
Well, a lot of that's still here. We still have the food carts. People still walk up the hill from Shockoe Bottom. So we'll definitely have to have you here sometime. Hopefully when COVID dies down, we'll have you here in person to kind of re-enjoy everything.
I would love it.
We had one question in the chat from Akshay, who asked, the face transplant was one of the most revolutionary medical advancements of the decade. What do you think the next major advancement in the field of reconstructive surgery would be if you're kind of look ahead?
I would say that dealing with facial injury and dealing with individuals that had facial injury as a result of IED, which is improvised explosive devices. I've cared for some patients from Walter Reed and National Bethesda, military servicemen and women, or individuals that have had ballistic facial injuries, that have a ruptured globe, that have lost sight. If we could give those individuals the opportunity to regain sight, I think that would be a tremendous advance in reconstructive plastic surgery. And it's something that we're thinking about heavily right now. Could we do it? How could we do it? And what would be the elements to make this successful? So giving an individual sight that had sight before but lost it as a result of a traumatic injury, I think that would be a remarkable advance and would probably lead to many other advances.
And I know we have you till 2, so I just want to do one last check for any questions.
Sure.
Hi, could you speak on the role of the Department of Defense's involvement in your research and work, since you brought up reconstructive surgery after traumatic injury?
Yes, so the Department of Defense has been heavily involved with us. There's a component of the Department of Defense which is called AFIRM. In the military, there are many, everything's an acronym. And AFIRM stands for Armed Forces Institute of Regenerative Medicine. And within that umbrella of AFIRM, they support stem cells, tissue regeneration, but also within that, there's tissue transplantation, there's face transplants, limb transplants, but it's all these elements of really advanced and sophisticated levels of reconstruction. So the DoD, through AFIRM, still today is very supportive of all our efforts. They provide a tremendous resource, not only of qualified professionals, but also financial backing for a lot of these clinical transplants, but also research efforts. So they're very heavily involved in supporting these kinds of causes, because it's not just for military personnel, but also they're heavily involved in solving problems for civilians that may not be military personnel. So they've been very involved with our program. We're very fortunate that they've supported our program. They support many programs throughout the nation, but they're very much involved in these types of transplants, but also in tissue regeneration and new fields that could help out patients with any type of horrific deformity.
Thank you, sir.
You're welcome.
And I'll just echo what Dr. Diorio posted. Thank you so much for, giving us your time and inspiration. It was incredibly profound for me to hear from you and kind of learn from your perspective as well. I'll leave the floor to you for any parting thoughts or any advice you can give us as we kind of move forward through our careers in medicine.
Well, I would say that the next challenges are going to be up to you. All of you carry the responsibility to care for those that are in unfortunate situations. And that's what we do. That is the oath that we've taken, and that's why we have chosen this field. We are passionate about this field. Whatever we do in this field, whether you're an internist or an ophthalmologist or a pathologist or radiologist or surgeon, all of us have the responsibility to care for individuals that are in devastating times of their life. However small it may be, take your job seriously. And remember that if you love what you do every day, you will never work another day in your life. I wish you only the best. You're a part of my alma mater. I'm incredibly proud of you. And if I could ever do anything to help any of you, I am here to assist in whatever manner I can. I wish you all the best, great success in your future medical careers, and hopefully I'll get to see you soon.
Dr. Rodriguez, thank you so much for giving us the time and everything. And thank you to everyone for joining us for this amazing alumni talk. Take care.
Take care. Bye-bye.
Thank you.